Um, so we have one more speaker before we go to our break. And that is Professor van Delden. There. Professor van Delden is a full professor of medical ethics at the University Medical Center of Utrecht University of the Netherlands. He leads the project on patient and public participation in care, education, and research. He has worked for many years as a practicing nursing home physician and has published widely on the practice and ethics of end-of-life decisions, research ethics, and ethical issues in the care of older people. Professor van Delden served as the chair of the International Bioethics Committee of UNESCO, the president of the Council of the International Organizations of Medical Sciences, and as the chair of the work group for the revision of the CIOM's ethical guidelines for biomedical research. Today, Professor Hans van Delden will share some bioethical reflections on the use of age in scarcity decisions. Thank you for being here.
Yeah, thank you. I'm going to do something very dangerous. Going to go a little bit against the stream here. Because I'm going to say that perhaps in scarcity situations, it is actually justifiable to prioritize the young. In order for my chances to walk out alive to increase, I'm going to tell you that, of course, I'm very vulnerable. I'm 65, by the way, so perhaps among the oldest of people here in this room. And of course, I also subscribe to the idea of having a rights charter of some sort which specifies and underlines the rights of older people. Great idea. I very much subscribe to the idea that we should make desegregated data visible and making sure that we have more data on older people. I actually also put the fact that I myself, as a medical doctor, worked as a specialist in care for the elderly. So yes, I very much sympathize with the position of many of you here. And I do subscribe to the idea that the rights and the needs of older people in humanitarian crisis need to be emphasized and underlined. But, here comes the but. If at the end of the day, you're going to push the buttons, right? Okay, so if at the end of the day, there's a lack of money, and by the way, probably that was already the case at the beginning of the day, then choices have to be made. Can I give you, yeah. Okay, so this is all clear, right? I mean, I don't have to tell you this. This is exactly what is in the thesis. And so, yes, older people are often twice as bad affected in humanitarian crisis. Absolutely true. And therefore, a rights-based framework for age-inclusive actions is indeed very welcome. Yeah, let's have the next slide. I think the previous speaker also mentioned, let's not pretend that the group of older people is actually homogeneous. It's not absolutely true. It would be rather inconsistent to treat all of them as vulnerable. I am really persuaded also by these pictures of older people actually doing a lot of healthcare themselves. And indeed, also in other situations, I've encountered that. So let's not pretend that they're all vulnerable, but still, some of them will certainly be at a greater risk of being wronged or incurring harm because of being frail, or as you said, because life slows down. So that's true. And I think, especially in situations of humanitarian crisis and in situations of scarcity, when these two come together, I think it's rather to be expected, unfortunately, that others will be less vigilant about the rights and interests of this group. I think that's exactly what you've all been showing, right? That unfortunately, well, what was it, 6% of projects don't even have something specific on, only 6% had something specific, so 94% had nothing specific on older people. And so indeed, there is a problem. Can I have the next slide? Yeah, if computer says no. Do you know these short movies on the internet? Computer says no. Absolutely horrifying, but often quite true. It's very British indeed, but okay. What is happening? Yeah, computer says no. I mean, that's okay. So I will simply continue because I will know what to say. There we go. Okay, so this is, I would say, rather straightforward from medical ethics. Let's assume that rationing is needed, right? That's my assumption. So yes, I'm for everything that will be said today, but let's assume that in some cases you will have to make choices because there's a scarcity of resources. And I'm also assuming, because I sometimes stop looking at the news or reading the New York Times because you get so frustrated. But I'm assuming actually that the number of cases in which rationing will be a reality is actually growing, right? Because funds are getting more limited every day. Yeah. Okay. So what can you do? Well, these are the four options. Sorry, Chris, not a fifth. These are the four. And if you do not choose, the fourth will happen. So that's the simple reality. It's just these four. You can do only one of these four, and if you don't do anything, the fourth will happen. So, in situations of scarcity, okay, make the scarcity go away by investing more money. Yeah, great idea. But unfortunately, often not very realistic, right? And nowadays, even less so. Number two, use resources more efficiently. Well, that is great. That is really great because in that case, of course, you have the same amount of money, but you have more outcome, right? You have more of the benefits that you're wishing for. So that's the way to go. You think. Quite often, there are silent victims there. For instance, when I worked as a nursing home physician in a nursing home, each year we got a budget cost cut of 1%. Okay, only 1%, but still. Because the government simply assumed that each year we would be more efficient, let's say by at least 1%. So the budget was simply cut every year with 1%. What was the effect? Well, of course, we kept caring for the same amount of people in the nursing home. They still got their care. But of course, there were hidden victims. There were less nurses, so less attention was given. The computer system was not renewed, so we still wrote on paper, which is okay. I don't mind. But of course, there are always hidden victims, and often it's the soft skills or the soft, let's say, endpoints that you're losing out on, right? Attention, care. I mean, nowadays, you know what the average length of stay is in the University Medical Center in Utrecht where we work? 4 days. In a university hospital where all the difficult cases come, right? So that's crazy low. 4 days only. What does this mean? It means that we have to sort of push you through the whole patient journey. With such a pressure that, of course, we're losing out on attention. You no longer come to the hospital the day before your surgery, you come at the morning because that saves 1 day. But of course, it also means that a lot of your anxiety cannot sort of be taken away by someone who listens to you. You simply have to do that yourself. Get up at 6, be there at 7, and be operated at 8 in the morning. Right? That's okay. So this is, of course, a stupid example because it's from a very wealthy nation in which a lot of things actually can be accommodated. But still, it's an example of how we push for efficiency and lose out on, let's say, care, attention, those kind of things. Still, I do think that perhaps this is the way to go also in humanitarian crisis, but we'll get to that. Okay, if we are out on efficiency and have done everything that is possible there, then we have to prioritize between interventions. The question, of course, is how do we do that? And we all acknowledge that if we use qualities, that they are inherently negative or have bad influences on the position of older people, right? Because, of course, the life years, LY, quality adjusted life years, will be less for older people. So in a way that is sometimes not the best way to go. And if nothing is done, then indeed there will be a situation of scarcity and a huge number of people actually hoping to get some of the, let's say, the benefits. And then waiting lists will come to exist or will be so long that people die on the waiting list. And so in that case, you will start to select people on the waiting list or on the there's not a waiting list in many situations. This is imaginary, right? So it's the people who would actually benefit from that care. And that's actually also where you might start to say, should we use age as a criterion for selection? Can I have the next one? I hope computer says yes. Yes, computer said yes. Okay, the use of age in selection is ambiguous because age is not just a number. Age is also a proxy for medical success. It can actually be true that sometimes certain interventions are less successful in older people, and that might be a reason, a medical reason, to use age in that sense. However, and that's I think the most important point there. What counts as medical is an ethical decision. Doctors in the room will not agree with me. They'll say, "Well, this is medical, it's fine." But I actually think that in a lot of cases, what counts as medical and what is seen as a medical, let's say, criterion, is actually in itself an ethical decision, because you will prioritize for some. If you prioritize for having the best outcomes, you will probably prioritize those who are not the most ill. If you prioritize for having those who are in the greatest need of your intervention, you'll probably prioritize who are most ill. And that in itself is not a medical decision. That is an ethical decision. So that's why I think if you use age as a proxy for medical success, then indeed you should also be clear about why you chose that interpretation of medical success and not another. Well, you could also say age is an indicator for proportionality. Yeah, you could argue that sometimes, let's say, the burden of certain interventions will be bigger, will be higher in those who are old, and that therefore it should not be done. But then, of course, there's a risk of paternalism because, yeah, who decides? I mean, maybe I would like to decide whether or not to have that intervention. So difficult there as well. The most straightforward use of age is age as a number. So irrespective of the specific health situation, irrespective of the medical success that might be implied in using age, if you use age as a number, and therefore also as an indicator for the phase of life, that's probably where age is most often used. And then, of course, we have to face that question, would that amount to a situation of discrimination? That actually has been said already, right? Because the first speaker used the word ageism over and over and over again. She's not here to defend herself, so I should be cautious. But I actually am not so sure. Yes, there is ageism, absolutely. But would this be ageism? Can I have the next? You would say, well, of course it is. Of course it is, because it goes against, let's say, the rights of all the people. And that's against whatever, all basic human rights, a yet to rights specific convention on the rights of all the people, whatever. You could argue that it is a form of discrimination. Is it though? Actually, you said something that very much helped me. I'm not sure whether you were like that, but you said you will all be old. I already am, but you will all be old, and that's true. So I hope that you will all be old, but it means that we all reach, if we continue to live, of course, a certain age. And we are able to reach that age by virtue of the fact that when we were younger, we were given priority. So if you take a lifespan approach to, let's say, this whole question, you could actually also argue that indeed all people are treated equally over the lifespan. So no discrimination, because discrimination means that we treat equals unequally, right? That's what's wrong about it. We treat equals unequally. That's what's wrong. However, if we say, no, 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 we treat everyone in the same way. Over the lifespan, we concentrate funds on helping you when you're young. And the consequence is, if you're older, yeah, then probably most funds have been spent. This is all imaginary, of course. This is not a reality. I'm not talking about budgets here, but as an idea, to say that to prioritize the young, for me, is not necessarily a form of ageism, is not necessarily a form of discrimination. Therefore, it could actually be justifiable. Can I have the next one? There are more arguments. Young people still have a life to live, clearly, probably similar to what I said before. Fair innings, I haven't heard fair innings yet. That should be here, fair innings. Right? The idea that all the people already had their fair innings. And of course, it will differ dramatically what those fair innings look like. Dying young is a tragedy. Dying at old age is a misfortune. I once was in Ghana and there was a funeral going on. And I noticed that one funeral, everything was in white, and another funeral, everything was black. I didn't understand. And then people explained to me, if you died under 70, black. If you died over 70, white. It's sad for those the relatives. It's of course the saddest, but it's not a tragedy because you died at a age in which, yeah, you've had your fair innings. So we can look differently at dying at young and at old age. Of course, you could argue all the persons have rights too, and that's exactly what you are striving for, and I agree. Yes, yes. Oh, I missed an S there, but you see what I mean, right? All the persons have rights too. That we show little respect for older people by using age as a selection criterion. I agree there's a risk here, there's a risk. And again, I very much subscribe to what you also said. Make it visible, look at their needs, make sure that you have, let's say, programs that also attend to their needs. Another thing is that if you deliberately choose for prioritizing the young, it might actually be that especially those who are working for MSF on the ground, yeah, you will have to face dilemmas, right? You're not helping this person, and you are helping this person, and probably especially in the reality of that moment, it will be very burdensome to make those choices because the rule of rescue dictates otherwise. You feel you have to respond to that person, right? You cannot leave that person alone, especially if that person has a face, as in you see that person, right? And then you have to decide, sorry, no. That is a very burdensome decision. So can I have the next? However, that's exactly what I think was accepted here in the Netherlands during COVID. It did not exactly get the approval of the government at that point. But indeed, some acceptability of selecting the young, I think, can be justified, and it was actually justified at that moment. However, if we continue doing that, then of course we would go completely off balance, right? And we would continue to give all the money prioritizing the young. So what I call an egalitarian correction is needed. And indeed, the convention that you plea for might be a first step. Can I have the next? So I'm still hoping to get out alive, right? It's too late. It's okay, Oscar. Yeah, okay. But the you said during your introduction, it need not be that way. You actually use the words that we perhaps do not have to choose between the old and the young. And if you're right, I would be so happy. Because then indeed, well, we can do the one and the other, and we don't have to sort of deliberately prioritize some people over other, which is in itself very problematic. I of course agree with that. So perhaps when we talked before this symposium, Elber, you said, well, if you distribute food that is uneatable for instance, these women because they lack teeth, right? I think that's what stood out to me most. But if you replace that food with something else that is actually usable for them, then perhaps you have created opportunities without losing opportunities on the other side, right? So yes, please be aware of their needs and make it visible and use it in data and think about it and indeed look at it with a lifespan. So not only over 60, I agree there, sure. And perhaps we can then escape from having to choose between the two. And minimum standards for age and disability, I think are needed. I think you should have some kind of minimum, a decent minimum. It's of course a very egalitarian thought for everyone. But, and that's the next slide. There is no next slide. Yeah, there is. Okay. But unfortunately, at least that's my premise. That's how I started thinking about this. Scarcity is a reality, both in healthcare, but also during humanitarian crisis. And some prioritization of interventions that benefit younger people, I think, could be justifiable, however painful. Absolutely true. And minimum standards, and I should add perhaps also that convention that you're promoting may function as an egalitarian correction. Now I'm starting to run. Okay, that's it. Yeah. Yeah.
Role is I work on disability issues, and I'm also from the UK. And almost everything you said feels very much like the recent arguments we've been having about assisted dying in the UK. All of these arguments, in fact, have been, promoted for the right of people to choose to die, to the right in Holland. So I guess if I took out the word older adult and put in disability, then the argument becomes much more difficult. Where do you cut that off? Someone who has a very severe disability someone has a very moderate disability, like, how do you cut it off? And then you're asking humanitarians to make a choice. Humanitarians already get accused of playing God. And so in this instance, they're really going to have to play God because they're making life and death decisions. So how would your argument, if we took out the age, put into both?
First of all, I didn't expect something about end of life here, in this sense.
But you brought it up because you're saying that older people will die soon.
Yeah, okay. I think in general, people with disabilities would have the same end of life rights as others. I don't think there's a scarcity issue there immediately. Well, there might be in terms of doctors willing to help, right?
As we saw in COVID.
Yeah. But leaving that aside, so my whole reasoning here, I mean, what I think is the strongest argument is this lifespan argument. And that, of course, fades away in the disability example. So I would really have to rethink that, because it's not true that we will all get disabled. Well, to a certain extent, yes, because old age comes with at least some form of disability. But I mean, the whole idea here is really age specific. It's really about age, because in the lifespan approach, it makes sense, actually, also for older people, to prioritize the younger if we continue doing that, because then they would have had their fair innings and their chances when they were young. So I don't think you can take this out and put in disability and then have the same result. Yeah, also, yeah, so I don't think it works that way. Sorry.
But it is a utilitarian argument, but
Yeah.
arguing a very utilitarian point. So
No.
logic would follow.
No. Thank you for that point. So am I a utilitarian? No, absolutely not. Is this a utilitarian argument? Well, in a way, no. It's actually the lifespan argument is not utilitarian. So I'm not saying you get less out of putting your money on older people than putting your money on younger people. I did not say that. And also I used an egalitarian correction, right? And that was sincere. So no, I'm actually an egalitarian, if I would have to give myself one hat. But I do think, and this is actually this is about rights, and this is about discrimination and what amounts to discrimination. And I don't think using age as a selection criterion necessarily amounts to ageism. That's my whole point. But it doesn't work that way in disability. I do acknowledge that. Yes, please.
Let's see, so many questions, great. Maggie was first.
Yes. Well, good morning, everyone. My name is Maggie, and I work a long time with MSF. I'm a medic, humanitarian, and specialized in sexual violence, intimate partner violence. And thank you for your presentation. So I would like to bring two reflections/questions. In one of your first slides, I personally felt it was quite a medical lens. For example, mental health was mentioned, though I think at a certain age, isolation also plays a role. And you quite quickly said, like, there's no fifth option. But then I was reflecting a bit myself, right? So, and then in the overview, I thought, where is then the community support system? You know, what could be done at the community level to make sure that people at a certain age also have access when there is food distribution or clean water or the piece of shelter which will be distributed, or, you know, just a chat for a cup of tea. So I'm I'm a very practical person, so that was one of my first reflections. Could we also apply a more social lens using resources from within community?
Yeah.
And see, can we play a role as MSF in mobilizing those resources?
Yeah.
My second question is, I felt a bit also, where is the support for a healthy lifestyle? Yeah. To support people to still be able to make a walk, food, all of that, alcohol, especially in different countries, smoking, etc., etc. So that were the two things from my side. Thank you.
So I don't think you say anything that I would disagree with. First of all, of course, I had a very narrow view. And the very narrow view, or the premise is, unfortunately, yes, even humanitarians will have to make choices, or humanitarian organizations will have to make choices. And now more even than before, maybe. And then can we use age as a criteria? That was my basic question. And of course, as you gave beautiful examples, if you have the community as a resource, and you can actually mobilize some of their powers to provide the attention that is needed, the care that is needed, great. In a way, I think you're then actually raising efficiency, or you're making it possible to, as you said, to avoid that choice between the young and the old. My basic question, and my only question, I'm not saying that I've covered everything that is on the table here, but my only question was, can we, in a situation of scarcity, justify prioritizing the young? My answer is yes. And that does sort of leave untouched that, of course, if we can also do something about lifestyle, and of course you should make sure. One of your pictures was, or one of the stories was that the older people were there and wondering why all these people with backpacks left the building, right, or the village. And so there was a lack of communication there. So yes, of course, you should do something about it. I'm not saying let's ignore the older people. I'm not saying that at all. I'm saying if we need to make a choice, then age can be used. That's all. So I don't feel that you have rebutted anything that I said. Yeah.
But do you want to go? No, sorry, then it's Amrish, Akina, Oscar.
Sorry, no coffee break.
Well, thank you for the very thought-provoking a lecture that you gave. I think it's much needed to have these discussions. And I think like when we speak about scarcity, there is like what type of scarcity we're talking about. So are we indeed talking about the code red within the clinic where we have to make choices? Okay. Now we have to have a strong triage system. Age, including physical conditions, can be included. But it's indeed also the dimension of the what role do older people play in our society? And I think it was quite nice. We had a discussion also in the Netherlands a couple of weeks ago on Code Red. And I think it's also about everything that starts before the point of delivering care. The role of elderly in families, for example, which was very evident during COVID, where difficult decisions had to be made as well, was the multi-generational households, for example, where have a huge role quite often in taking care of grandchildren. Yep. And that in itself has severe impact on social cohesion in society, continuity, economical impact, whatsoever, especially in a vulnerable context. And one of the things that I think is important that we also, especially with the medical lens, kind of like insert that into the equation, which is often let out. So it becomes very quickly a utilitarian kind of decision, but it's a utilitarian decision that is kind of missing some key components, namely the key components that take place outside the hospital or point of care. And otherwise, yeah, I do agree, age can be included, but there's so much more indeed between the dichotomy that we definitely can do, and at the moment we are not doing. And that's probably what we should be focusing on, because it's true, the choices we'll have to make because of resource scarcity will become more difficult. And if we don't have a rationalization framework with very clear examples of what we can do without putting additional resources in terms of funding or putting more pressure on our staff, apply all these different lenses, it won't work. And we'll make bad decisions all the time.
The point also about putting more pressure, that's also what is called efficiency, right? To put more pressure on your personnel. And of course, that's not going to work. Probably there's a lot of pressure already. Augmenting that is certainly not going to be the right way. So again, yes, absolutely true. Happy to endorse everything you said. But if you have to make choices, blah, 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 I think I made that one. And of course, I mean, please, as a nursing home physician, as someone working in elderly care, yes, a physician, sorry. Indeed, I think we could do a lot more. I mean, is the Netherlands a dementia-friendly society? No, it is not. I've criticized the fact that we talk hours about whether it's okay for demented people to ask for euthanasia. I would rather spend those hours differently. So, because for me, it's dramatic that we in the Netherlands spend more time on inventing a way for you to ask you to be killed, because that's what it is, rather than creating a dementia-friendly society, right? So, are we putting the wrong emphasis? Yes, we are. All of that is true, but that was not the key of the key component of my talk, right? Okay. You have a list.
Sorry, yeah, we have Vila, and then we have Oscar, and then Oscar.
And then you need the break.
Yeah.
Thank you, Mr. Frans. It's a very interesting discussion, definitely not to be resolved in 4 questions or 4 comments. I come here mainly as a clinician. Yeah. Some of the comments has been already mentioned. I found myself during COVID making the same assumptions of resource scarcity or dichotomy between saving lives and which age groups. So just a quick reflection. I mean, the humanitarian mantra says save lives and alleviate suffering. Most of the time we are focusing on the save lives and not on the alleviating suffering part. The last Lancet Commission on pain and palliative care mentioned the increase of what we call serious health-related suffering that has increased up to 70% since 1990 to 2000. Approximately measures pain, distress, conditions that may not be resolved. And unfortunately, the data represents that this will increase like around 75%, especially on older adults, older women, more than 70. This management of suffering is something that we are not counting. I mean, many of the proxies are economical proxies we are measuring. So just a reflection, I'm not saying anything with this, just some data to ask the question, when you highlight there, when it may be justificable to benefit younger people, what's the final purpose? Because here, for example, if I put it from the clinical perspective of alleviating suffering in humanitarian context, there's no justification. Prioritize younger people. So I wanted to know your reflection. Yes, no, give it back to you.
So I think this actually resonates with what I said before, that when we use age as a medical criterion, then we actually jump over the ethical discussion that is behind that, and that is, what exactly are we counting, measuring, prioritizing? And yes, great example. If you only prioritize, let's say, survival and not quality of life, then that's a choice, and it's an ethical choice, and it's something to debate, and it's not something that can be hidden behind that word medical, because often medical functions as a screen, right? Oh, it's medical, then it's for doctors, and then we can no longer think about it. But that's not true. What you count as the most important medical endpoint is in itself an ethical choice, and suffering might be a better endpoint than survival alone, or maybe a combination of the two. Yeah, so I think we were.
when you are talking about the justification of the prioritization of intervention and benefit younger people,
Yeah.
what's the final objective? That was my question.
Yeah, and I agree. Let's talk about it, because I'm not the one to decide all that.
Otherwise, no one can hear it.
Okay, no, but I think this was the end of this discussion, right? Okay, do you want to add more? Okay.
Hans, thank you very much. It was a wonderful presentation. Please don't leave before we take care of you. Thanks everyone for being here. And I'm obsessed with the meaning of things, but I wonder if everybody knows what fair innings and what innings, where does it come from? And we are not in an Anglo-Saxon audience, so innings is a metaphor taken from cricket or from baseball, which is basically a turn behind the bat. I know you probably haven't seen cricket, but just being able to have a turn behind the bat. So fair innings, they had enough turns behind the bat. Hans, thank you very much for having your turn behind the bat. We will have our turn behind the bat now during the break. Break will be 2 minutes. We'll continue at 12 o'clock.